Record on this computer. All right, so we are recording the debate about universal public health care, public health insurance for all citizens. And just for posterity on this video, we had 12 people vote for the issue, only 3 vote against, and 1 person is undecided. So kind of curious if anybody changes their mind after the debate, but right now it's 12, 3, and 1. Okay, so I would like to give the floor over to Charlotte, and looking forward to your presentation in the debate. So here she is.
Okay, like you said, this topic is extremely complex, and a lot of people have already made up their minds about how they feel, and a lot of them are strongly either for or against public health insurance. First of all, let me just kind of briefly go over what universal health care is. The most significant goals of universal healthcare are to improve healthcare outcomes for everyone, while also establishing effective cost controls throughout the healthcare system. Universal healthcare would ensure universal access to health services. Those health services would be of high quality, and receiving health services would not put you in financial harm. There are 3 types of universal healthcare that are seen around the world, in every other developed country besides the United States. Let's see. About half of all developed countries have a single payer universal healthcare system. Single payer means that the government provides insurance for all residents or citizens and pays all healthcare expenses except for copays and coinsurance. So there's still some expense from individuals. Providers can be public, private, or a combination of both. In a single payer system, the government pays for medical care and restricts alternative payment mechanisms for services that it covers. So they might say that you can have additional coverage that you pay for out of pocket, but you might be restricted for having coverage for things that the government already includes in the single payer system. One note, in England, one difference between their healthcare system and in like a healthcare system as in Canada, they actually have government-owned health facilities, hospitals, and they employ the healthcare professionals, and that's government funded. In the US, we actually have something similar to that in our Veterans Health Administration. The hospitals are owned by the government and the healthcare providers are employees of the government. 2 other types of universal healthcare that exist around the country, around the world, are a 2-tiered system. And that is where the government provides or mandates catastrophic minimum insurance coverage for all residents and allows for additional voluntary insurance and fee-for-service care when desired by the citizens. There's also insurance mandate universal health care, where the government mandates that all citizens purchase insurance, whether from private, public, or nonprofit insurers. In some cases, they restrict the list of insurers, but in other situations, in other countries, they have a system of insurers that is a very healthy private market for insurance, very robust and an open market for insurance. It's simply regulated and standardized by the government. In that type of universal healthcare system, insurers are barred from rejecting sick individuals, and individuals are required to purchase their own insurance in order to prevent the uninsured. let's talk about what we have here in the United States. One other note about different types of universal healthcare systems. When we talk about like the total cost of healthcare, universal healthcare systems usually cover between 70 to 85% of total healthcare expenditures because they provide comprehensive basic healthcare and allow for the purchase of additional coverage by citizens. So when we talk about the U.S. versus other countries, even though it's 100% coverage in universal healthcare countries, the total healthcare expenditures that makes up is less than 100%. So our target is not full funding of all healthcare expenditures. It's somewhat lower than that. In the United States, we have a mix of public and private, for-profit and nonprofit insurers and healthcare providers. About 55% of the US population is covered under employer-sponsored health insurance. The government provides funding for Medicare for adults 65 and older and some individuals with disabilities, as well as insurance for veterans and some low-income citizens through Medicaid, and for children through the Children's Health Insurance Program. The Affordable Health Care Act was the largest expansion of our medical system, of our Medicare system, and that occurred in 2010. The ACA required that most insured obtain health insurance or pay a penalty, which has since been eliminated. But it allowed children to remain on their parents' private insurance plans until age 26. And it set up health insurance marketplaces that offer premium subsidies to lower and middle income individuals. Back to the employer-sponsored health insurance. The employer-sponsored health insurance is not directly subsidized by the government, but there's a hidden subsidy there. The tax exemption that is created by the employer-based insurance system is estimated to be worth about $260 billion per year. Due to the tax exempt status. This is a diagram of what our healthcare system looks like. You can see that privately insured individuals have three options. They are either covered by an employer-sponsored health insurance plan. They can purchase health insurance through the government subsidized marketplace, or they can purchase health insurance directly from a private insurer. About 34% of Americans are covered by a healthcare system insurance program sponsored by the government, and those are Medicare, Medicaid, the Child Health Insurance Program, and the Veterans Health Administration and TRICARE for active military. Okay, so in 2017, the spending, public spending accounted for about 45% of healthcare spending, or approximately 8% of GDP. Federal spending represents 28% of total healthcare spending, and federal taxes fund public insurance programs of like Medicaid, Medicare, CHIP, and the VA. I skipped a slide here. Sorry. So there is still, even though we have all of these insurance programs that cover most of the citizens in the United States, we have an uninsured population that's still 8.5% of the U.S. population. It's about 28 million citizens. These individuals account for about 18,000 premature deaths annually. The acutely sick or uninsured receive fewer and less timely healthcare services, resulting in worse outcomes and increased morbidity. They're less likely to receive preventative or screening services, resulting in increased risk for more severe health consequences. And about half of all personal bankruptcies are caused by medical debt. So expenditures in the US are split about 55%, 45% between private and public expenditures. In total, about $2.8 trillion. But what you should note more is that we spend overall on healthcare a significantly higher amount on healthcare overall than in other countries. Public spending supports approximately 34% of the insured population, but a similar percent of GDP as countries that provide universal health care to all citizens. This isn't a reflection of the significantly higher cost. This is a direct reflection of the significantly higher cost of healthcare in the US versus other countries. According to the nonprofit consumer advocacy organization Public Citizen, healthcare spending is estimated to continue rising and will reach $6 trillion a year by 2027, which is more than double the current annual total healthcare spending. That means over the next 10 years, we will spend $42.9 trillion if we keep the status quo. This is another just a slide to show the rising percentage of GDP. 1 in every $5 spent in the United States goes to healthcare spending. This shows a chart of typical expenses in the United States versus other countries. If you look to the right, showing 100% is the US price, and what percentage of price is spent by other countries for similar hospital and prescription drug benefits. Most people pay half as much as we do for all of these items. So, you know, this significant cost, according to the Brookings Institute, to see prices so far above other countries reflects what they call rents, payments to health care system, to the healthcare system beyond what is necessary for the normal rate of profit. These rents are driven by market imperfections, including provider market power and difficulty that healthcare patients and other payers have in assessing prices and quality. In addition, excessive administrative costs and general higher wages for the highly educated workers in the United States contribute to the relatively high US prices. Another reason that our prices are high is that competition is unusually weak in our healthcare system. Consolidation of medical providers, barriers to market entry, and the closing of some hospitals has led to a high and rising market concentration, which allows providers to set higher prices without losing patients. Consumers that are not able to observe price and quality differences between different options suffer from surprise billing. Surprise billing is when insured patients find out after receiving healthcare services at an in-network facility that a provider, a surgeon, an emergency department staff, or an anesthesiologist was outside of their insurance network and is consequently much more expensive than they had anticipated. This raises the cost to consumers and allows providers to charge higher prices than those that were negotiated by insurers, raising overall costs. This often occurs in emergency rooms and when people have little or no ability to compare prices and to choose the best option, even if they were aware that there was a price difference. Specific medical providers who often have the ability to engage in surprise billing include practitioners like anesthesiology, emergency medicine, diagnostic radiology, pathology, and these types of providers often charge 5 times that of the Medicare allowed amounts. So healthcare costs in the United States are the highest in the world, and they make up about a third of all healthcare costs. Administrative healthcare costs are higher as a share of GDP in the US than in other countries. In the US, also provides generous patent protections for drug makers, allowing them to charge high prices, making prescription drugs more expensive than in other countries. Some of the other challenges we face, 40% of Americans are obese, which has led to costly health consequences such as diabetes and heart disease, which are more expensive to treat. Consumers, again, are not able to observe price and quality differences between different options. Economists also point to the role of new technology adoption contributing to costs. And while you would immediately think that that's a good thing that we have new technology, oftentimes it is without regard to whether or not the new technology is an improvement over old technology. We move fast, we adopt new technology and prices increase, sometimes not due to improved outcomes. And another reason, doctors are well compensated in the US compared to other countries. So that makes our healthcare much higher than in other countries. This just gives you a comparison of the United States to Canada and England on a few different items: per capita spending, out-of-pocket spending, spending on pharmaceuticals, and hospital spending. And you can see that the United States is more expensive in every category. And we don't really fare any much better when you look at like how often or how quickly you can be seen by a doctor to get a same day or next day appointment, or to get after hours care. It's pretty comparable to other countries that provide universal health care. And if you see experienced access barrier because of cost in the past year, the cost in the United States prohibits a lot of people from seeking medical care. A third of all American citizens say that they have had to limit access to healthcare because of cost. And again, we have the issue of the prevalence of obesity and the higher mortality rate in the United States based on our healthcare system. So what do other countries do, and how do we compare? In Canada, 100% of citizens are covered. It's federally regulated. Provincial and territorial territories are finance and administer the programs. It's financed through federal and provincial and territorial taxes. The federal government in Canada sets the national standards for medically necessary hospital diagnostic and physician services. The local, provincial, and territorial governments are primarily they are the primary source for financing, organizing, and delivering healthcare services, and supervising providers. Each province and territory has a health insurance plan that covers all medically necessary hospital and physician services on a prepaid basis. While 100% of citizens are covered, it funds about 70% of total healthcare expenditures in Canada. Supplemental services, or those not covered under Canadian Medicare, are largely privately financed, either through patient out-of-pocket payments or through employer-based or private insurance. 2/3 of all citizens in Canada also have some form of complementary insurance, 90% of which is based on is offered through their employers, which accounts for about 12% of total healthcare spending. That private healthcare service they cover items that are excluded under the universal healthcare coverage, including vision and dental, outpatient prescription drugs, and rehabilitative services in hospital and private hospital rooms. Each province and territory's health insurance plan covers, I think I just, hold on. Supplementary services or those not covered by Canadian Medicare are largely privately financed. Sorry, I think I've um, overall, the healthcare spending in Canada is about 11.5% of GDP. So how does Canada control prices? Um, Costs are controlled principally through single payer purchasing, and increases in real spending mainly reflect government investment decisions or budgetary overruns. Cost control measures include mandatory global budgets for hospitals and regional health authorities, negotiated fees schedules for providers, drug formularies or provincial drug plans, resource restrictions for physicians and nurses, such as provincial quotas and for students admitted annually, and restrictions on new investment in capital and technology. The Canadian Agency for Drugs and Technologies in Health oversees the National Health Technology Assessment Process, which is a mechanism for containing new technology costs. The Federal Patented Medicine Price Review Board is an independent quasi-judicial body that regulates the introductory prices of new patented medications, keeping prescription drug costs down. In addition, the Pan-Asian Pharmaceutical Alliance has also negotiated lower prices for 95 brand name medications, and has set price limits at 18% of equivalent brand name drugs for the 15 most common generics. Another similar developed country to the US is England, and they have a health insurance. They've had health insurance, universal health insurance, since 1948. Healthcare in England is managed by the National Health Service, and universal healthcare is available for all residents, generally without cost sharing. The National Health Service pays for preventative care, hospital care, including outpatient drugs, physician services, some dental and vision, mental health care, palliative care, some long-term healthcare, rehab, and home care, with specific coverage determined at the local level by one of the 209 clinical commissioning groups in the country. It is not a single payer system, as private insurance is available to pay for more rapid access to care provided by the National Health Service, in particular for elective hospital procedures. 100% of citizens are covered by their universal coverage, and approximately 10.5 also purchase supplementary coverage to ensure more rapid access to elective care and other services. The majority of the National Health Service funding comes from general taxes, and a smaller proportion, 20%, comes from national insurance, which is a payroll tax paid by employees and employers. The National Health Service also receives income from co-payments and people using the National Health Service as private patients. Total healthcare spending in England was 9.9% of GDP in 2004, and was with 79.5% made up from public funds, and 14.8% was out of pocket. Costs are contained with a nationwide global budget that is allocated to the clinical commissioning groups, and hospitals are owned and staffed by the government. I threw one more country in here just because I thought this was interesting. I know it's not to scale for comparison with the United States, but Taiwan's national health insurance system was designed on the US Medicare system. It provides universal mandatory coverage. It's a single payer system funded primarily through payroll-based premiums. Although the government provides generous premium subsidies for low-income households, civil servants, and others. Funding for their national health insurance is split between the government, employers, and the insured, with a typical employee paying 30% of the premium and low-income people paying nothing. Government funding comes from general revenue plus tax and lottery taxes, tobacco and lottery taxes. In addition to premiums, the insured pay copays for physician care and prescription drugs and coinsurance for inpatient care, with those costs limited for disadvantaged populations and citizens with certain diseases or conditions. I wanted to put Taiwan in here for another reason, because their system is such a low cost system. It's 6.2% of GDP as of 2014, with 12.1% of healthcare spending out of pocket. And the remarkable thing is they do this with an administrative cost of just over 1%. Costs are managed through global budgets with average annual growth under 4%. To combat high utilization, additional copays have been instituted for seeking care without a referral. Capacity is constrained. There are fewer physicians and CT and MRI machines in Taiwan than other countries, but there's no waiting time. It's non-existent. Every participant has a mandatory electronic card that tracks personal health information. Aggregate utilization statistics are used for planning and budgeting. So I just thought that was an interesting healthcare. So what are the benefits that universal healthcare could provide to the US? Universal screening and prevention would allow for a more targeted approach to intervention for obesity, diabetes, and heart disease, resulting in a reduction of costs and of costly long-term health consequences. Consolidation of services would eliminate and elimination of compliance and means testing would reduce administrative costs. Surprise billing would be eliminated, and adverse selection would be eliminated. So not surprisingly, I would imagine for most of us, the universal healthcare receives its largest support from the only stakeholders that are concerned about health outcomes above profit or politics. 60% of Americans are in favor of universal healthcare, which is about what we see in our class today. Most doctors are in favor of a universal healthcare system as well. So in conclusion, the US healthcare system is complicated, costly, and values profit over health outcomes. Yes, providing coverage to the 8.5% of citizens that are currently uninsured can't be done without increasing total healthcare costs. But the economic and social benefits of providing healthcare far outweigh the costs. Universal healthcare is a proven method to improve health outcomes, as demonstrated by every other developed nation in the world. We've allowed in the US for-profit entities and politicians to sway opinion away from the only thing that should matter, health outcomes. And our population suffers because of it. Cost savings could result from reduced administrative cost, prescription drug price regulation, and there's really no reason why the US couldn't use the most why the US couldn't be a leader in providing healthcare to its citizens. We're a wealthy, developed nation. Our current healthcare system is not desired or emulated by any other developed nation. We have the ability, as it stands, to base a universal healthcare system on the best practices of all other developed countries that have already found ways to provide healthcare for their citizens. So depending on what form of universal healthcare takes and how the tax structure is set up, in the US, it is entirely possible for individuals to pay less due to the current cost of premiums, copays, deductibles, and other out-of-pocket expenses. So the overall cost is more, but on an individual basis, it may benefit some. Universal healthcare can't fix every healthcare problem. Every country with universal healthcare still has problems with healthcare, but it doesn't mean that we shouldn't move towards a single payer system here in the United States.
Okay, thank you, Charlotte. If anyone has any real quick questions, we can have them, but I think we should give Philip some time. Go.
All right, everyone
2:41
can hear me
already.
clearly?
You have a question?
I said everyone can hear me clearly?
Yeah, I can hear you.
Okay, perfect.
I can turn my volume
Can
down
she
a little
stop
bit.
sharing hers? It's saying someone else has to stop sharing.
Yeah,
Oh,
Charlotte,
yeah.
you need to unshare probably.
Thank you, Charlotte.
Here you go.
Okay, so I want to say that I took before I get started on anything, I want to say I took the against position primarily because I'm against a universal public option as in a universal single payer system. I'm not against changing the current US healthcare system because I think it's I'm not sure anyone would disagree that it's not very good right now. So Charlotte made a really good argument, but I think I have an interesting one that's worth listening to, and it's not the status quo. Now, first thing that hit me, and this is why I did not like the idea of universal public healthcare, is it's expensive. It's really, really expensive. And I will get to later why I think like the costs may actually hurt more than the benefits, because there are benefits to it. Now, according to a study done by Charles Blahhouse, the cost over, I believe it was 10 years, would be $32.6 trillion. This was using math done from Bernie Sanders' Medicare for All proposal. I can't remember the acronym Bernie Sanders used specifically, but it was done from his bill. He roughly averaged it out to about 2.5 trillion per year increase in federal spending. That's on top of I believe the 1.7 trillion we spend right now when it comes to subsidies for public health care. And this study wasn't on its own. Like every study so far that has been done by various different institutions, some of them like more libertarian, some of them more progressive, has said that it's going to be about 2.4, 2.5. I think the Urban Institute was between 2.5 and 2.8. Kenneth Thorpe, he said it was going to be about 2.4. In every case, it was more expensive. And now Bernie Sanders, I believe, estimated it would increase by about 1.7 trillion. But when his number is the outlier when compared to every study that's been done on it by virtually everyone. So now also costs to fund universal healthcare. The study that I mentioned by Charles Blahhouse, you would need to double taxes on both corporate income and personal income, and that would not even pay for the full financing of it. That means even if you doubled all income taxes, whether it be personal or profits from corporations, I mean, it still wouldn't pay for universal single healthcare in our country. And this is using math from Bernie Sanders' bill. Now, on top of that, so if you want to still fund single payer healthcare, you would have to decrease government spending on some other program. The question is, what program would you want to decrease it on? A lot of people make the argument for military spending, and you can decrease some, maybe, but we're not. Decreasing spending on military isn't always such a good idea when we're considered the greatest power in the world, and there's a lot of people that are increasing military spending. It's when we have countries around the world trying to overtake us, I guess, in some ways they already have. It may not be a good idea to decrease military spending, and I know people wouldn't want to decrease Social Security spending, and that's the other real big item in the federal budget. So in order to fund this, according to data from Bernie Sanders' bill, you would have to double taxes, and you would also have to decrease spending somewhere else. Now, everyone here, I'm assuming has heard of dead weight loss. We've all taken Econ 101, where you impose this tax on an economy, aggregate economy, like a small like market, or in any way, it leads to a dead weight loss in the economy. Doubling the tax rate on corporate and income taxes is going to lead to a big dead weight loss on the economy. Slower economic growth that's what would result from it. Now, the implementation of a single payer healthcare, as I said earlier, would have positive benefits, but it would also have the negative externalities of the dead weight loss from the massively increased taxes. I do not like. I want to say, and I'll get to this later, that I am definitely someone who is for improving healthcare. I actually chose this topic because I got into a debate with one of my friends, and she said, well, you don't want single payer healthcare. You must not want to improve our healthcare system. It's like, no, I just don't think single payer itself is the correct solution. Now, on balance, would the benefits be positive or negative? The positive benefit would be better health of virtually the entire population. Everyone would receive healthcare. The answer is a bit ambiguous, but I would argue that doubling the US tax rate and cutting spending in other areas where the government funds things would probably lead to a net negative benefit in this case. Now, I heard this talked about, and I wasn't going to discuss it till I heard it talked about in the last class. And this study I mentioned earlier by Mr. Blahouse is the quote unquote Koch brothers study. And the study was indirectly financed by Charles Koch. The problem was when I heard Koch study, the author actually went and talked to factcheck.org because he said, I did this independent of anyone. It's not really fair to call it the Koch study when he did this without any input from anyone. Just the foundation he works for is funded partially by the Koch brothers. And I wanted to say this because it was mentioned in last class, talking about the increased cost of healthcare. I believe it was from 59 to 57 trillion spent on healthcare if we implemented single payer healthcare now, because it would streamline everything. It would do all these things to cut down administrative costs. The problem is that cherry picks data. That's one good item, and the author himself disagreed with the characterization of his work. He said, that's Bernie Sanders. That's what Bernie Sanders says. That's not what I say about my work. Now, the slight decrease in healthcare costs overall, I mean, $2 trillion is a lot of money, but compared to the over 50, almost 59 trillion we have right now in healthcare spending, it's not all that much. And this is over a 10-year period. We don't spend 59 trillion this year. It's over a 10-year period. Now, it's, again, I come back to the negative externalities of having to increase taxes to fund this. I just see them as really, really bad. And this leads me to, I took the against position, but I hate saying I'm against something without having another solution to the problem, because I don't think the current situation is where we should be at either. And I did some research, and my alternative solution is an integrated delivery system. This is something that we actually have in some areas of the country right now. And it is a self-contained healthcare ecosystem that includes everything from care to insurance to every step of the healthcare process. It essentially streamlines all of everything within the healthcare system. Every like step of healthcare, that's why I put the graph in there, whether it's extended care, community health, and like having to go take an ambulance for your preventative care, all of that is streamlined to a single ecosystem. And it cuts out the middleman. Insurance companies aren't separated from the healthcare companies, and the healthcare companies aren't separated from the insurance companies. There's no back and forth. That's not extra administrative expense. It streamlines everything. And in every study I looked at, there was one in particular by, I believe it was Elaine Enthoven, who essentially, in all of the research he's done, he's been talking about integrated delivery systems for a long time. In virtually every situation he looked at, an integrated delivery system provided better healthcare for everyone involved and lowered costs for everyone involved, both people and companies. It was better healthcare with lower costs. And in one of the studies I looked at, it was as low as 28%. There was another study I looked at that summarized 20 separate studies, peer-reviewed studies, and in 19 of the 20 studies, there was a lower cost of healthcare. In 20 of 20 studies, there was improved healthcare. Now,
Hey, Phil, I'm sorry. Can you go back to the last thing?
Yes, sir.
I'm sorry to interrupt you like this, but like pretend that we don't know anything about what you're talking about. And the graph here, can you say anything about who is paying for all the care here? Like what?
Okay, so it is healthcare. Like when you would join an integrated delivery system, you're a person paying for your healthcare. It is a healthcare system. I'm not saying that we shouldn't have some form for people that are jobless or can't afford healthcare at all. I'm saying overall this will increase the number of people that can have healthcare on top of part of the system we have now.
Is it so? Are you saying that you pay for it, like you pay to join?
It's almost like a one-stop shop for healthcare, where you instead of having insurance and paying for doctors
or something where you pay a fixed amount to be in part of this system?
Yes.
Okay. So it is like an insurance system, but without the insurance company.
Insurance is part of it. Everything, like when I say integrated delivery system, I mean every step of healthcare, from insurance to the actual care to surgery to everything.
But there is no insurance company for profit in this model.
I'll get to that later.
Okay. Go ahead. All right, go ahead.
Okay. And another thing about the study that I had, an integrated delivery system aligns incentives better than the traditional service fee model, which is what we have now mostly, in the single payer model. In the study, another study done by Alan Enthoven, he observed that in the integrated delivery system that all of the incentives of both the consumers and of the firms align better with an integrated delivery system than in a single payer model and in a traditional service model. It also, I talked about this a little bit in the last class, but I don't like the idea of forcing people to get healthcare. And I believe everyone should get insurance, get healthcare, get all of that. But I believe that people should have the right to not have to. And this is still a private system where the government is allowed to get involved. And I will talk about, Charlotte mentioned drugs later, and I'd have a rebuttal for that later. It wasn't included in my slides, but towards the end. But I don't like the idea of forcing people to do something. I love the history of this country because it's a constant improvement of individual liberty for everyone. It started out where it's just white people, and now it's getting to the point where it's everyone. And I love that story of people being able to do what they want to do with their lives, and no matter who they are. And I like I'll mention them later, but competition is still present in this system. It's not the government entirely doing this as an overlord of the whole medical system. There's still competition between companies. And I believe competition in this case will drive down prices as integrated delivery systems become more present. And it also, we don't need to fund this. This is a private system. You don't need to raise taxes to fund it. Taxes can still stay where they are or go lower. And the negative externalities of raising taxes with deadweight loss will also be gone. These are some of the integrated delivery systems I talked about. This is where I got my idea for this from. I'm sure everyone on there's heard of the Mayo Clinic before. That's a horizontal integrated delivery system. It's a little bit different from the vertical ones, but it's still, if anyone who's ever talked or heard about the Mayo Clinic, it's usually considered either the top one or two hospital systems in the entire country. All of the Kaiser Permanent is basically what I was talking about. It's a vertical integration system where it's insurance companies come together with medical providers and all kinds of things. And one thing that Charlotte mentioned that I mentioned too is doctors are paid really well. It's usually a service fee system for doctors. In integrated delivery systems, they're paid a salary. So it caps out the cost. It caps out the cost of labor a little bit, and it lowers the costs of it. Now, I wanted to say that I don't mind if we could afford a single payer system, I wouldn't mind the idea of it. I'm I believe that everyone should be allowed access to healthcare, but I just don't. I see that integrating a single payer system into our economy as it stands, as even with the cost reducing measures that Bernie Sanders put in his own bill, it still would not be enough to pay for the ginormous tax burden that would be needed. And I would like to say that I didn't know about integrated delivery systems before this. I had to, when took the against position, I had to be more than against to me. I had to actually find another solution that was less costly. In my mind, an integrated delivery system is a better solution because it also increases care in every study ever done on it, and it decreases costs in every study ever done on it. And I believe that would be a better way forward. Our country has always done things a bit different from other countries, and I didn't, just because, why not we be the one that try this as our primary form of healthcare? If every other country's trying this, why can't we try? If it's something else, why don't we try this? And we might be the ones that lead other countries towards this. Now, I wanted to, now that I've gotten, this is the end of where my debate was, but I want to also talk about drug pricing, because that's a really, really good point, and I have a problem with it too. I do believe that there, in this situation, depends on how much it costs for the drugs to be made, but definitely in almost every instance, drugs are overpriced. My dad is a pharmacist at Costco, and he talks about it to me all the time, how overpriced drugs are. And I believe that actual federal regulations when it comes to drug pricing are definitely necessary. I do not believe that drugs should be such a higher price in our country than they are in every other country. And I believe that on top of it, if you do that with an integrated delivery system, it would be more cost effective than a single payer healthcare system with cost controls on drug pricing. I guess I'll let Charlotte respond, but that, in case anyone has, if she doesn't respond, if anyone has any questions for me about this, healthcare is really complicated, which is why I picked it, because I knew it would be hard. So if anyone has any questions for me, unless Charlotte wants to respond, I'd be happy to take them.
I guess my only response with the integrated delivery system would be scalability. I don't know how large these systems are, and also when you talk about like aligning incentives for consumers and firms and providers, I mean, the incentives for consumers are, better healthcare, better outcomes. For firms, it's profit. So how does it benefit firms and providers? I mean, does it improve their profit margin?
It actually depends. Some of the integrated delivery systems are nonprofit. Some are for profit. In either case, it's shown to have lower cost. And the reason that it's cheaper for the consumers is the administrative costs are vastly lower because of the integration. They are still getting the profits they want, but it's cheaper for them to do it. And if anyone looks at a supply curve, it'll shift it to the right when the inputs are cheaper.
Do you know what the size of the largest integrated health
that would be
is?
Let me go to my Kaiser Permanent, I think, is about 12 to 13 million provided. I can do a Google search. I believe it was like 12 to 13 million people are signed up for it. It's like 8 or 9 states. That's the biggest one. The most well known one is the Mayo Clinic, but the biggest one is the Kaiser Permanent. It's 12, 13 million. That's why I was saying there's still competition, because there would be multiple of these. I just see it as an improvement on both single payer and on the fee-for-service system, the traditional fee-for-service system.
So one question is, we already have these things, don't we?
Yes, that's why I brought them up.
Yeah. So there's something you said, like it would be good if we could do this, if we as a country could do this. Aren't we already doing it?
Not to the extent I would like, if that makes sense.
Yeah, but so how so the question, I don't want to steal your thunder, Charlotte, if you have more questions or rebuttals. Should I give you a chance to go, or do you
No,
want
go
to?
ahead.
You sure? Okay.
That's fine.
No, I mean, this is every integrated delivery system is something you have to pay to join.
Yes.
And what do you do about people who can't afford it?
I don't believe that we get rid of I believe we also have to reform our current Medicare system.
Okay.
Like for the people that can't afford it, I'm saying that that safety net still needs to exist.
Okay.
I'm also saying that an integrated delivery system will allow more people to afford, like it will increase the amount of people that can afford healthcare, on top of having the safety net for the people at the very bottom that can't afford any kind of healthcare.
Right. And another speculation I have is that the reason these haven't grown up to the scale of the whole country is because so many people have employer-sponsored health insurance. It's still above 50%, right? Charlotte,
Yes.
it was 55. And so are you suggesting that the government gets involved to get people to leave their employer-sponsored healthcare and join these systems? Or like individuals
how you would like implement it on a wider scale?
I guess so. I guess, like right now, people are free to join these if they want, but
they're available they're not as widely available, I'm saying, as I would like them to be.
Yeah.
Like there are maybe, like the biggest one is the Kaiser Permanent, but there may be like 20 across the country that are like big enough to be considered an integrated delivery system.
Yeah.
I wonder what the premium pricing difference is between that and the average cost that people pay now. Is it lower?
The cost was about 28% lower, if I remember correctly.
Yeah.
That was from one of the studies. I'd have to go back and look at more of the study. That was the one I put in my slide, but I have to look at more of the studies to see like what the average was.
Do you guys remember in the article about employer-sponsored healthcare I asked you to read, it did say one of the reasons so many people are doing this, and it started to suck up all of the health insurance in the country, is that there are some tax incentives to do it. I think Charlotte, you mentioned this too. That
I kind of dropped off some of the information that I probably should have provided about, it drives down wages, because when healthcare costs go up and the insurers choose to, take on more of the premium on behalf of their employees, they're not doing that entirely altruistically. They're doing that because they have the tax incentive to do that. And that keeps wages lower in the United States.
Yeah, and even workers may prefer to have health benefits instead of income.
And they know that. The employers know that.
Right.
And so, employees will see their stepping up to pay increased premiums on their behalf as a good thing, which it is too. But but it also keeps employees from demanding wage increases too.
Yeah. So I guess my point is, if you're trying to get people to leave their employer-sponsored healthcare and join an IDS, there has to be something different also about the tax codes in order to incentivize them to do that. Because I'll take myself for an example. At VCU, I get healthcare that's pretty cheap for me personally because it's the employer is paying for it. I would have no incentive to leave VCU Health and join an IDS because of the way this. You would have to somehow change the way I'm compensated in order to nudge people to join these in order for them to get larger. Wouldn't you agree? And I'm saying that's an issue. That's like an obstacle. You have to change a lot about the tax code in order to get this. I see that Gibran has raised his hand. Does anybody want to say anything, or I'm going to go to Gibran? Gibran, you want to say something?
Sure. I'll go, and then I see Nick has his hand raised, so he can go after.
Oh, he does.
I don't want to diverge too much from the talk about healthcare, so you can stop me if you want, Professor. But I think this is an important question because Philip, you used this as an argument against taking spending or reallocating spending from other sectors of the economy and putting it into healthcare. So like with regards to the military, for example, you said something, I wrote this down, you said something about how we can't really reduce their military spending right now because you said that other countries are, what did you say? You said something like, God,
I think he said
actually,
take over, but maybe he meant overtake.
yeah, so you said
Sorry,
other
yeah,
countries
that
are
was bad wording,
overtaking
but
us.
yeah.
I think he
Can you
meant
elaborate
overtake.
on that?
I think he meant overtake in terms of like global power, right? He didn't mean literally invade our country, although maybe he did. I don't think he did.
But can you
Right,
still
Philip?
elaborate on that in terms of
You elaborate.
overtaking us in terms of global power? Because even that's, I'm a little skeptical on that statement alone.
I believe that some of the countries that would overtake us are, if we were to decrease our military spending, would be a net negative for the globe in entirety if they were to become the more stronger power and us the lesser. I believe, like as a bloc, I believe NATO is a very good thing for the world. And if there were other countries that became strong, and I can't remember the exact percentage, but our military is a huge share of NATO. I guess that's straight from healthcare a bit, but if we were to allow these other countries that do not have good moral codes to overtake us in military spending in military might, as an overtake NATO in military might, I don't see that as a good thing for the world. Unless they change their moral value system, then I don't see that as a good thing for the world, I guess, if that makes sense. So I should have been more explanatory when I gave it the first time.
So you're making like more of an argument about like the US's role as like a world police. Not
Yeah,
like,
as in us as a world power, the predominant world power would be better than is China with its current moral system as a world power.
Yeah, this is a big debate and kind
Yeah,
of
that's what I'd
strays
say.
a little
It's
bit
getting
too
it's
far
getting out
from
of healthcare
healthcare.
now.
But
that's why I
China
said you
only
could tell me
spends
whenever.
10% of their GDP on health expenses, and they have universal health care.
Yeah,
Oh
yeah.
shit.
Right. And so, I mean, that's ultimately what this is about. Like, should we switch to universal health care? Would the cost be? I really like that, Charlotte. It's like right at the end, you got to a point that I thought was extremely important, which was that even if taxes go up, it's possible that individuals save money because they don't have to spend healthcare premiums, right? It's almost like a way to reframe this as you don't just care about how much money you're paying in taxes, you're caring about how much money you pay in taxes plus how much healthcare premiums you have to pay. And if the amount your taxes go up are more than offset by the healthcare premiums that you no longer have to pay, then you can actually think of this as individuals saving money, right? I'm pretty sure you made this argument right at the end.
Yeah.
And that's, of course, in terms of framing, you have to frame it this way in order to get people on board. If you just ask people, hey, should we do universal health care? Everybody's taxes are going to go up. They're going to probably say, no, we don't want that. But you have to frame it in terms of your taxes go up, but your premiums disappear. And it could be that you actually save money that way. Now, not everybody's going to save money. We have a very progressive tax system in this country. So I don't know about very, but we have a progressive tax system. So the richest people are probably going to have to pay even more because of it.
I did see one proposal that with universal health care that they could mandate employers pass on their employer share of premiums to employees as wages as part of the universal health care system.
So people would see their wages go up.
Yeah.
Their taxes go up and their wages go up. Yeah. I mean, that's how you have to frame it, I would say. You did a good job. What about this issue of rationing? You guys in the class, I'm sorry, Nick, did you have your hand up? Go ahead, Nick. Go to Nick.
Oh, so let me unshare this now, unless anyone wanted to look at something else on it.
I might, I don't know, you might have something that would answer one of the questions I've got here about the IDS system. So when you're talking about the IDS system reducing overall cost, the number you cited was 28%. Is the mechanism through which these costs will decrease, like is the idea that the competition between different firms in the marketplace will lower prices over time?
It's like almost like a two-edged thing. So
Okay.
there's two different ways that I know of, and I have to look more deeper and deeper into this because I will for my paper. First off, it makes cost of healthcare for the company is cheaper to administer. On top
So
of that,
it's essentially harnessing the idea of monopoly markets and like vertical integration and trying to use
it's
that to
vertical
decrease
integration.
cost.
There's also horizontal integration, which is a bit different, but vertical integration to make it more efficient to deliver the healthcare. And that's why I mentioned the supply curve, because it's cheaper to do it. So now the supply curve shifts out, and on the demand curve, it's a lower price.
Okay. Well, I guess
The other thing was, yes, competition between them would drive it down as well. So I said
gotcha.
two-edged sword.
Okay, so the follow-up question I have to that then, if we're kind of relying on market structure to provide some of these like positive effects, one, I mean, it seems to me like when we're looking at this problem, one of the primary issues in terms of why our costs are so much higher is one, that the majority of the market has a profit incentive, whereas in a single payer government funded healthcare systems, there's not a profit incentive. And then number two, you know, because there are significant barriers to entry into the healthcare market, like I could try and create a healthcare company tomorrow that would enter the market, but it would take a lot of negotiating. I'd have to go and negotiate with doctors, negotiate rates, set up administrative systems, stuff like that. That would make it incredibly difficult for new entrants into the market, ideally. So, I mean, I don't know if we'd be able to get like the full range of positive effects from a competitive market by just kind of looking at this and getting that out of, hoping that that's what we get out of it. And the other thing that we have to look at, I think, is the elasticity of demand for healthcare. If there's a profit incentive in an IDS system, and these firms are, if we assume that they're profit maximizing or at least profit satisficing firms, then the fact that people are willing to pay significantly, you know, like that the price of healthcare has very little effect on whether or not people pursue healthcare would seem to indicate to me, at least, unless there's like another explanation for how this wouldn't work, that like that would just lead to more profit taking in the healthcare industry. So, I mean, and that would only work because you don't have, you know, the barriers to entry would make it more difficult to get the desired level of competition to where it would actually push prices down, right?
There's a lot of good points in there. I also wanted to point out that in most of the cases, the IDSs are nonprofit.
That's what
right. But if there's suddenly a huge market and, you know, prospective entrants who do have the, you know, capital requirements or the ability to enter the market do see that, then, I mean, they're going to be looking for the profit.
But entering the market with like the nonprofits are going, because they're doing it to essentially a nonprofit generally does their work to help others. Like they're giving healthcare at what it basically almost at cost for them.
Yeah.
Versus like, I guess, having savings for variable costs later. Would they be able to push the cost up if we have these people in this integrated system that already have their lower costs? They're not going to raise it because you have these other people entering. The people entering are going to have to lower their costs because these nonprofits already have their costs lower.
But these nonprofits aren't nationwide, right? So, I mean, it would depend on the location of the market, because healthcare isn't like a national marketplace. It's very much a local one. You can't really go to a hospital in Utah if I'm getting sick here in Virginia.
Yeah.
So, I mean, unless we have like a nationalized nonprofit.
Some of the IDSs are multi-state IDSs. The bigger ones are. So I'm saying it definitely can be a national thing.
Mm-hmm.
I'm not saying it's not going to be complicated to like put in place. Like there's a lot of good points you're making. I'm saying cost-wise for both like consumers, the government, like employers, I'd see it as a better option than single-payer healthcare.
Gotcha. It's an interesting idea. It just looks like, you know, in terms of like the negative costs from one versus the other, it's like half dozen of one and then 6 of the other.
Healthcare is complicated.
Putting in the chat, we're out of time. Did anyone change their stance? Let me know if you were for and you're now against or undecided. Mihak, you could be the one that determines if she's still here. You were undecided before. If you had to choose now, would you want universal healthcare or not?
I'm kind of still unsure. I definitely want to change, but you know, the current system is not like the best system that we could have.
Yeah.
but at the same time, a little confused about like having universal healthcare. And that is why I would maybe agree more with Philip rather than
So
Charlotte.
you're against. Okay. If you had to pick, you'd be against. Okay.
Yeah.
Thank you. We are out of time. I mean, you guys said so much today that I couldn't really even repeat it back to you and have the class say what they think. But that's okay. I mean, unless anybody else has any really important things, we can end the class here. I do want to give you guys a quiz, and I'll make it available for 24 hours again. But don't forget to take it this time. Some of you forgot. I'll send an announcement.
Yeah, definitely.
Yeah, I'm looking at you, Joseph. Don't forget to take the quiz. It will be over. It will be over what we've just talked about, which is healthcare, also health insurance, right? The market itself. But it's open book. It's open note. You can go ahead and use your stuff that I've posted you for this, made available for this class. So if you do have a question about it, I guess I won't be on Zoom because the class ended. But just email me if you have questions or something. Tony says, what's the quiz on? Health insurance and healthcare and universal healthcare. And there were 2 articles I asked you to read. One was from Loophole to Mandate. The other one was Moral Hazard and Adverse Selection. So I could ask you questions about those 2. I will make the quiz in some sense timed. I don't want you to maybe, and you can only take it once, but I'll give you a lot of time. You can choose when to take it, but I'll give you like, is a half hour enough? Let me give you more time than a half hour, 45 minutes at most. I don't think you're gonna take that much time on it. I just don't want you to. I just want you to just take it once, and that's it. I think
Is the quiz becoming available now or on Thursday?
now, and then